Ma'am has an MSK fellowship from Singapore. She joined Sion as faculty and is associated with LTMMC from May 2005. Her areas of interest are musculoskeletal imaging as well as cross sectional imaging. And ma'am has over 40 national as well as international publications. Today's topic for ma'am is bowel imaging but not cancer. I request you to share your screen, ma'am. Ma'am, we can see your screen, but I think you need to unmute yourself.
Okay.
Yes, ma'am. Now you're
You are able
audible.
to hear me loud and
Yes,
clear?
yes,
Okay. Okay. My talk would have little bit repetition of Dr. Ruchita madam's, but no worries. We can have a revision. So what I'm going to do is non-malignant bowel pathologies, and my presentation would be a case-based presentation. So this is what we will be trying to look at in this 40 minutes presentation. So the commonest manifestation of TB is pulmonary TB, but second commonest is the abdominal involvement, which is seen in accounting for around 5% of tuberculosis cases worldwide. Now, when you are diagnosing a TB, GIT TB, you have to take extra intestinal findings also like lymphadenopathy, peritoneum, and other solid organ involvement. The features, clinical features, as you're seeing it, they are non-specific. Lab parameters, if we get gene expert for peritoneal TB, it will be fantastic. But sometimes we may not get the classical investigation pointing towards TB. So what is done in that case? In that case, a therapeutic trial of ATT is given, and response for the therapy within 8 weeks is considered. And if the patient if the patient is responded, then it is considered as a criteria for TB diagnosis. But the accuracy for this is around maximum around 30% only. So where in GI the TB is seen? As you all know, the commonest involvement is the ileocecal and the ascending colon, but rest of the bowel loops can also show presence of involvement of TB. So why ileocecal rejunction? Because there is increased rate of absorption due to physiological stasis and abundance of the lymphoid tissue, which helps in growing up of TB organisms. And the ileocecal region TB, that is a GI TB, is commonly associated with peritonitis. There are three patterns which are commonly seen: the ulcerative, hypertrophic, and the fibrous stricturing, which can progress from ulceration to direct fibrous stricturing, or of a hypertrophic progressing to stricture formation. The another common pattern is also a hypertrophic pattern, which is commonly seen in Indian population. Extraintestinal changes, we will get lymphadenopathy, the typical necrotic lymphadenopathy, which might be conglomerate and matted in appearance. Abdominal cocoon formation, we will see how it looks, and omental thickening. Colonic TB, if you have to think about colonic TB, it is a differential diagnosis for most of the colonic cecal lesions. But if you get an associated extraintestinal finding of ascites, peritoneal thickening, and lymphadenopathy, typically necrotic, we can confidently give colorectal TB as a diagnosis on imaging also. So coming to case number 1, she is a female child coming with history of Cox contact. The right-handed sections are showing the plain scan, and the left-handed are showing the post-contrast imaging. You can see that there are enlarged mesenteric lymph nodes which are matted and necrotic in appearance in view of peripheral enhancement. The next section, the cecal and the IC junction thickening is seen. Let's see in coronal sections, matted conglomerate lymph node showing peripheral enhancement pattern suggestive of necrosis. As I'm moving further, there is also presence of ascites. And in this area, this is the ascending colon, this is the ileum. There is enhancing wall thickening of the ileum associated with adjacent necrotic lymph node, and also the ascending colon is also showing a wall thickening. The IC junction wall is also showing humongous thickening, giving an inverted umbrella appearance. So this is a classical TB. Now, there is this another patient who has come with pulmonary Cox and she is on TB treatment since 1 month. Let's see the axial sections. As we are scrolling through these axial sections, what we are seeing. My cursor is seen, I hope so. Yeah. So this is the colonic loop. Anterior to the colonic loop is the omental thickening, which is nodular and in a cake-like pattern. Also note that the bowel loops are indiscernible. They are appearing conglomerated in appearance. The mesenteric fat shows multiple strands suggestive of fibrotic mesentery pattern. In this coronal sections, what I'm trying to show you is the bowel loops are matted. Mesenteric shows multiple fibrotic changes, and encircling this bowel, matted bowel, is a thick, irregular, enhancing membrane, which is nothing but a cocoon formation. This is also called encapsulating peritoneal sclerosis. Another patient, 70-year-old male, who has on and off fever. He has also history of PRN melena, suspected colonic malignancy on clinical examination. What do we see over here? In this axial section, there is circumferential enhancing wall thickening of the ascending colonic loop. At the same time, this colonic loop thickening is also extending up to the hepatic flexure. And in these two coronal sections, we can see that the colonic loop thickening is there in its entirety. There is pericolonic fat stranding. The peritoneum, this thin membrane, is also appearing thickened. And look at the IC junction, which is also thickened. So in view of this pattern, the possibility of colonic TB was given. So this turned out to be colonic TB. Now here is a female who has history of pulmonary TB, has taken ATT. The predominant finding is ascites, centering of the bowel loops at the center, along with mesenteric haziness. There is also seen mesenteric, little bit of mesenteric congestion. And if you look carefully, there is a thin membrane over here, which is appearing irregular nodular marked by blue arrow. And this is just the start of a cocoon formation. In coronal section, centrally placed bowel loops, cecum contracted, thickened IC junction, and a thin membrane. I hope it is seen well. A thin membrane suggestive of early cocoon formation. So if you looked at the early and the late features of bowel pattern of TB, they are not very specific. They can go with any other pathology also. Like small bowel fistula sign can also be seen in subacute bowel obstruction also. So when do we say that the patient is suffering from bowel TB? So if the patient is having involvement of IC junction associated with either a finding of contracted cecum or a long segment abnormal terminal ileum or a stricture of ascending colon, then we can highly say that imaging features points to a TB. However, the matting, dilatation, and thickening of the small bowel loops are considered non-specific features. Coming to case 4. Look at these images concentrated on the ascending colon. So we are going from up to down. As we are reaching towards the cecum, there is circumferential wall thickening. How is the wall thickening? The wall thickening is showing homogeneous enhancement pattern. But as we go towards the inferior, that is the base of the cecum, there is a hypodense wall thickening, suggestive of an intramural hypodensity. There is also pericolonic fat stranding and a thickening of the adjacent peritoneum. Coronal sections showing the base of the cecum is more inflamed. It is showing hypodense wall thickening. The peritoneal is thickened. Compare with the left-sided peritoneum, the right-sided peritoneum is thickened. And the IC junction is normal. In view of IC junction being normal, this cannot be TB. This is a suggestive of an infective colitis. Now, I have not given history for this patient. Now, this patient was also neutropenic. He was a known immunocompromised status patient. So, in a patient with the neutropenia, having cecal wall thickening, which is hypodense in appearance, in suggestive of intramural hypodensity, intramural hypodense collection or an abscess formation with peritoneal thickening. This is suggestive of typhlitis. Female coming with abdominal pain since 7 to 8 days with increase in pain since 2 days. The history is acute. What do you see? Circumferential wall thickening causing mild luminal narrowing. These are plain cuts. On post contrast, how is the wall thickening? The wall thickening is showing bilaminar pattern of enhancement. There is hypodensity and the serosa is thickened and showing more enhancement associated again with peritoneal thickening. Few lymph nodes are there, but these are non-necrotic lymph nodes. On coronal sections, it is better observed that the oral contrast within the cecal wall and the proximal ascending colon is going in the crevices, that is within the haustral fold. They are entrapped within the haustral fold, and the base of the cecum is showing little hypoenhancement as compared to the serosa. This is again a feature of an infective colitis. Case number 6, patient again coming with a acute history, but also had bowel diarrhea 3 weeks back, for which the patient had taken antibiotic ciprofloxacin in her case. There is bowel wall thickening. How is the bowel wall showing enhancement? This is a plain cut. These are post-contrast cut. This is the delayed cut. So from plain to arterial to venous to delayed phase, the wall enhancement is more hypodense as compared to our this case where there is little bit of more enhancement of the bowel wall in terms of serosa. Here the serosal enhancement is not much, but there is more of hypoenhancement in the submucosal region. So submucosal edema. So there is a submucosal edema pattern. Also note that the ileum is also showing a similar enhancement pattern, that is hypodense with a thin peripheral serosal enhancement. The coronal sections showing again there is presence of an ascites. The entire colon is involved with IC junction thickening and the terminal ileal thickening. So how is this pattern seen? So this pattern is seen like an accordion pattern because of the edema of the haustra. The fluid, the oral contrast is trapped within the haustra, giving a black and white appearance of an accordion, also known as thumbprint sign. So why does it happen? Because the bacterial flora is lost, there is a gram-positive anaerobic infection by the organism Clostridium difficile, which gives to the pattern of enterocolitis. So infectious colitis, where does it can be involved by bacteria, viruses, or parasites. So in case of small bowel infections, the proximal bowel affection is generally by Giardiasis or strongyloids parasite. Salmonella shigella typically involves the distal bowel as well as the colonic loops. And whenever there is a pancolitis, think of Clostridium difficile, cytomegalovirus, or E. coli. The 38-year-old fellow coming with diarrhea since 10 days and has noticed weight loss. Coronal sections front to back. So these are arterial phase, stomach, the colon, and the small bowel loops. The colonic loops are unremarkable. This is CT enterography. If you look at the bowel loops, the ileal loops are looking okay. The proximal ileal loops are showing intense enhancement pattern. What about the jejunal loops? Jejunal loops are looking the jejunal loops are looking okay. So the main thing what we are seeing is increase in the mesenteric vasculature. The bowel loop is showing complete circumferential intense enhancement. And if you look at this particular bowel loop, the enhancement is more on the mesenteric side at this in this particular loop, with the anti-mesenteric border showing a normal enhancement pattern. Now this is typically specific for Crohn's disease along with the Coombs sign. Also note there are presence of lymphadenopathy, as madam had already said in talk. The Crohn's disease lymph nodes are nearly oval in shape and they shows intense enhancement. Now this particular bowel loop is showing mural stratification. We'll go to that in next slide. So here, if you look at this particular bowel loop, the inner wall is showing more enhancement The outer wall is also showing enhancement. The submucosal is showing less enhancement. This is called trilaminar enhancement pattern or mural stratification, commonly seen with the acute enteritis of Crohn's disease, associated with Coombs sign due to mesenteric engorgement. Also notice that there is increase in the submucosal fat as compared to the other dilated bowel loops. Case 8, this is a known case of Crohn's disease. Here what we are noticing is a soft tissue density lesion with these 1, 2, and 3, 4 bowel loops coming in close proximity to each other with perienteritis in fat inflammation is seen. Associated with it, we are seeing there is little bit of increase in the vessel enhancement with mild engorgement, suggestive of focal mesenteric congestion. So this is another case of Crohn's disease in an active stage. So phlegmon formation, if there is a necrosis, we will label it as an abscess formation. So at this moment is a phlegmon formation with adherence of the bowel loop. Again, you also note that there is a stricture formation seen in this MEP image with proximal bowel loop dilatation. The sagittal section showing increased enhancement with adherence of the bowel loops to this phlegmon. Now, this patient had also undergone CT 2 months back and had come as a part of a disease activity monitoring. There is also sacroiliitis in this patient. Now, this scan dated 2020 shows that phlegmon shows multiple air foci, which was nothing but related to the air. Now, here I am showing you the most important finding of the chronic Crohn's disease. Chronic Crohn's disease. See the bowel loop thickening and see the fat. So there is a mesenteric fat which has reached up to here, and there is mesenteric fat hypertrophy, also known as a fat creeping sign. So phlegmon formation with adherence of the bowel loops, increase in the fat at the adjacent to the thickened enhancing bowel loop. This does not have that mural stratification enhancement pattern. Coming to the next case, a female coming with occasional vomiting and diarrhea, and now she has presented with fever. So if you look at this particular loop over here, what is the pattern? It is a stellate pattern or star-shaped pattern. The multiple small bowel loops coming in close proximity to each other with adherence. The enhancement pattern of this bowel loop is again a bilaminar pattern with increased inner wall and increased outer wall enhancement with submucosal edema. Also, there is presence of a collection adjacent to the inflamed bowel loop, which is extending in the muscle. Notice there is ill-defined soft tissue with extensive fat stranding adjacent to it, suggestive of phlegmon formation. So this is a feature of a chronic Crohn's disease. So mural stratification, trilaminar pattern of enhancement, stellate pattern due to enteric fistulae formation, suggestive of chronic Crohn's disease. So Crohn's disease typically affects terminal ileum and proximal colon. The small bowel predilection is a more, and fecal calprotectin is a biomarker which is used for monitoring the disease as well as to differentiate it clinically from inflammatory bowel versus irritable bowel syndrome, which is a functional disorder, while inflammatory bowel disease is a disease of a mucosa. So if there is an increased fecal calprotectin, it suggests there is inflammation in the bowel. Acute features, as we have already seen, there is hyper enhancement of the inner wall. There can be bilaminar, as in this case, or a trilaminar enhancement pattern, where engorgement of the mesenteric vessels, presence of a submucosal fat, perienteric fat stranding can be seen in acute phases, and abscess and phlegmon formation is a feature of an acute stage of Crohn's disease. In chronic disease, there would be stricture formation with or without upstream dilatation, and there is fibrofatty proliferation adjacent to the thickened bowel loop which is suggestive of a creeping fat sign. A male coming with occasional diarrhea and anemia and has a recent complaint of blood in stool. That's why has come for examination. Looking at this plain cuts, what do you notice? The cecum is well distended. There's no wall thickening. But if you look at the left-sided colon, there is increase in the wall thickening of the left-sided colon. On a coronal and sagittal reconstruction, this colonic thickening is involving the entire flexure. The cecum and the ascending colon looks fairly okay. The IC junction shown over here looks okay. These are plain cuts. Also note that there are little bit punctate areas seen adjacent to the pericolonic region, which are nothing but prominent vessels, suggestive of congestion. And how is the wall enhancement? The wall enhancement is diffuse, homogeneous, with smooth serosal pattern. And there are areas of fat standing in the adjacent fat. So we know we are dealing with left-sided colonic disease. Are there lymphadenopathy? No, there is just signs of inflammation seen over here. In the arterial phase, note that increase in the congestion in the pericolonic region with a tiny lymph node over here. And the entire colon is showing enhancement at its more so at the inner wall. So looking at it, you can think that maybe this is a Crohn's. This is because the colon entirely is involved. But note that there is loss of haustral pattern. So this is an acute stage of the ulcerative colitis. Another case, plain and the post contrast and the MIP image. What does this show? The right-sided colon is showing a wall thickening. How is the enhancement? The enhancement is seen at the periphery, that is the serosa is enhancing, but the submucosa is showing hypoenhancement, and this is submucosal fat. In the coronal reconstructed images, there is presence of a stricture without any bowel dilatation. And the colon involved is both right as well as left-sided colon with involvement of the transverse colon, which is showing increase in the pericolonic vasculature with presence of a stricture showing mild dilatation. So there are mixed of findings. There are loss of ostration. There is presence of stricture with and without dilatation. And also there is signs of little bit of active inflammation. So this is active and a chronic phase of a chronic stage of ulcerative Crohn's disease. Note over here again the enhancement pattern. So ulcerative colitis as compared to Crohn's is more prevalent in males. The important point to note is it is associated with primary sclerosing cholangitis. The patients of PSC will develop inflammatory bowel disease in at least 70 to 80% of the cases. And within these 80% cases, 87% of these patients can develop ulcerative colitis. So ulcerative colitis is more predominant as a form of an IBD in a patient of primary sclerosing cholangitis. Another point, as the disease go in a chronic stage, there is increase in the risk of the colorectal carcinoma. After 10 years of disease, there is increase by 1% per year in chances of patient having colorectal carcinoma. The complication can be a toxic megacolon due to atonic colon, and this can undergo perforation. Sometimes the ulcerative colitis can in a later chronic stage can progress to the Crohn's disease. So inflammatory pseudopolyps may be seen if the bowel wall is well distended, which are this pseudopolyp is nothing but a normal mucosa, but normal mucosa remaining mucosa which shows normal enhancement pattern. And in case of chronic, we can see submucosal fat deposition as we saw in our second case, which is also labeled as a fat halo sign. Now here is a young female who is coming with abdominal pain, loss of appetite, loss of weight since 2 months. She is also having parameters like CRP, which are normal, but ANA is increased. So what is the predominant finding? What you are seeing in this case? The first image, the plain, arterial phase, venous phase, and the delayed phase. These are the ureters. So if you look at the bowel wall thickening, the bowel wall thickening is seen in the small bowel loops as well as in the colonic loops. How is the bowel wall enhancing? The bowel wall is showing hypoenhancement It is more towards the fluid pattern of enhancement. It is more hypodense in the submucosa. Also, there is entrapment of this fluid oral contrast, which we have given within the thickened haustral fold. On this plain and post-contrast image, we are also able to see that the vessels are mesenteric vessels are very prominent. The vessels are adjacent to the colon are also very prominent, giving rise to comb sign. If you look at these jejunal loops, the jejunal loops are showing mucosal spikiness. There is concertina, conniventes is thickened. And on this MIP image, there is typical Crohn's sign seen with few lymph nodes. So the involvement is of the entire colon, all these small bowel loops associated with little bit of ascites. So this is pan-enterocolitis. So when you get a pan-enterocolitis, the possibility is of a infective disease, as we had already discussed. But in this patient, there was also a factor SS antibody which was positive. So this is SLE related enterocolitis. So in this case, this pattern is of an acute pattern of an pan-enterocolitis of infective or inflammatory etiology. In view of SSA antibody being positive, this is labeled as a SLE enterocolitis. So this is a table showing the differences between the involvement of infectious colitis versus Crohn's, backwash ileitis of ulcerative colitis, and typhlitis. I will not go much into the detail, but the important point to know is typhlitis is seen in an immunocompromised patient. So if you see any wall thickening of cecum or ascending colon, and if there is neutropenia, then only you can label that patient as a typhlitis. Otherwise, it will fall into the spectrum of infectious colitis. So this is from one of the article in IJRI by Dr. Raju Sharma, wherein it was discussed if there is a bowel stricture, what should be the next step of management. If imaging features are typically of TB and Crohn's disease, the treatment should be followed up. But if the bowel wall involvement is suspicious, then the next step is the capsule endoscopy, provided there are no strictures on CT enterography. And if it is negative, then no treatment. If imaging wise it is normal but clinical suspicion is high, then to capsule endoscopy is recommended to look for negative or positive findings. Coming to next case, the patient having increased WBC count with acute pain in abdomen. The history is acute. As we are going further, the predominant finding is seen as mesenteric fat standing. There is a free air focus seen. And as I'm going towards the inferior cuts, there is a collection of peripherally enhancing collection with few air foci within it. This collection is in midline, extending up to the pelvis. One of the bowel loop is seen reaching up to it. And if you look at this colonic loop, there are outpouchings filled with contrast, suggestive of diverticuli. In this case, these are cecal diverticuli. And this collection is getting opacified by the oral contrast. So in coronal image, IC junction is normal. The cecum is pulled up. This is the appendix, which is stretched by this collection with leak of the contrast within this collection. So this is appendicular perforation with sealed of bowel perforation with appendix being adhered to this collection. Notice there is surrounding fat stranding and also cecal diverticulosis, but there is no diverticulitis as there is no pericolonic inflammation. Next patient, the patient has history of CBD stenting and again increased WBC count. This hyperdense structure is the stent, showing an ill-defined soft tissue with hyperdense areas within. On post-contrast, there is peripheral enhancement with internal no enhancement, suggestive of collection formation with presence of air fluid, a few air foci within. There is hyperdensity, which is showing no enhancement. Where is the location? Now, this location of the collection is behind the duodenum. If you look closely, you can trace this duodenal loop and this collection is in retroperitoneal location posterior to the duodenum, suggesting there is duodenal perforation, retroperitoneal duodenal perforation with formation of retroperitoneal hematoma. Patient coming to emergency department with acute abdominal pain since 1 day. She has abdominal distension and tenderness. The plain cuts. The predominant finding is ascites and dilated bowel loops. The small bowel loops are shifted to the left sided of the abdomen. The dilated air fluid level is also seen in the pelvis. Let's see in contrast. Stack of images from superior to inferior. So as we are going down on the right side of the abdomen, we are seeing a dilated bowel loop with haustral pattern suggesting this is colonic loop. This is humongously dilated. Fecal matter. As we are going further, look at the swirling of this bowel loop along with the mesenteric vessels which are looking engorged. Notice the vessels. This is artery vessels. Notice the vessels on this side. They are normal looking, normal dimension with good contrast enhancement, while these are looking engorged and looking hypoenhancing. As we move further, this dilated bowel loop has twisted and there are presence of two loops which we can trace right up till the pelvis with no bowel wall enhancement. There is absolutely no bowel wall enhancement. If you can discern carefully, there is a presence of a thin, paper thin wall with fluid in between these two dilated air fluid level structures. Let's see in coronal, how does it look? So in coronal, this is the twisted bowel loop with this bowel loop showing no wall enhancement. Comparison for plain and the post contrast for the vessels are not showing much enhancement. So this is right-sided colonic volvulus. This is not sigmoid volvulus because we have already seen in the axial phase that sigmoid colon was normal. So this is right-sided colonic volvulus with involving of the hepatic flexure and the transverse colon, with this portion of the bowel colonic loop being gangrenous. Patient was operated. You can see normal looking small bowel loops and a gangrenous loop from the right side. This is the abdominal cavity, retracted speculum. This is the colonic loop, which is gangrenous. Case 15, coming to a patient who is having watery stool since 2 days, and she has an history of exploratory laparotomy done for ovarian cystectomy on the right side 4 months back. Contrast, jejunal loops and the ileal loops. So there is dilatation of these jejunal loops with oral contrast seen in these jejunal loops and water fluid seen in the distally dilated loops. Notice there is an abrupt change in the dimension of one of the loop marked by yellow arrow. In this coronal reconstructed images, entirely dilated small bowel loops, the jejunal as well as the ileal loops, change in the dimension of the loop at the right iliac fossa. Now, this patient had a history of right ovarian cystectomy. So, this dilated bowel loop is a thickened bowel loop related to adhesions at the operative site. Let's see the axial sections. Concentrate on this bowel loop, which is looking narrow in caliber. The wall enhancement is there, but it is not humongous. It is mildly thickened, narrowed bowel loop, suggesting that there is an adhesion leading to a stricture formation. Now, as I am going down inferiorly in the pelvis, if you look at this loop, there is nice wall enhancement. But if you look at this loop, there is no enhancement of this bowel loop. These two bowel loops appear conglomerate in appearance, like forming one big collection. So this is suggestive of again adhesions related small bowel obstruction with the distal ileal loop showing bowel wall infarction. Also notice presence of fluid in the pelvis. So there is this collection, compare with the bowel loop, no enhancement of the bowel loop at all. Maybe there is paper thinning of the bowel loop. So what is mesenteric ischemia or a bowel wall ischemia? Mesenteric ischemia is is thrombus in one of the mesenteric arteries causing bowel wall changes. Now, in arterial pattern of ischemia, you will get paper thin presence of bowel loop, while in the venous pattern of ischemia, there would be more of a circumferential bowel wall thickening with decreased or increased enhancement. There would be presence of mesenteric edema, presence of ascites, and if there is increase in the severity, we might see portal venous gas and pneumatosis intestinalis, that is air in the bowel wall. So the commonest cause of bowel wall ischemia is arterial embolism or arterial thrombosis, where the basic enhancement pattern is absence of enhancement with paper thinning of the bowel loop, suggestive of gangrenous segment, while mesenteric will show significant bowel wall thickening. The patient with a normal CBC count and intermittent abdominal pain, what do you think there is? We are looking at the small bowel loops, they are looking normal, no dilatation, no wall thickening, there is no fat stranding. Look at the colonic loop. If you observe at the colonic loop, there are multiple tiny outpouchings showing fluid within it, showing the oral contrast extending within. This is nothing but diverticulosis without inflammation. Inflammation of a diverticulum is called diverticulitis. This is diverticulosis because there is no inflammatory changes adjacent to this bowel outpouchings. Now, this is another case wherein the blue arrow is pointing towards peripherally enhancing hypodensity within the sigmoid colon. Look at the sigmoid colon. The sigmoid colon is showing the wall thickening, presence of diverticuli. Perisigmoid, there is fatty infiltration. So this is suggestive of diverticulitis with an intramural abscess formation. So World Society of Surgery has divided the diverticular disease into uncomplicated and complicated type. So if there is only presence of thickening and perivisceral increase in the pericolonic fat density, then it is uncomplicated. It is considered to be complicated if you get any small air foci adjacent to the diverticula, suggestive of micro perforations or presence of abscess or presence of fluid in at least two different distal abdominal quadrants. So these are the different stages of complicated diverticulitis. Coming to miscellaneous cases, these are only, I think I have only miscellaneous 5 cases. Do I have time or am I taking more time?
Ma'am, 2-3 minutes more.
Yeah, 2-3 minutes are enough for me.
Okay, ma'am. Thank you.
Okay, so these are like short cases. A patient coming with chronic constipation. What is the major finding? The major finding is we are seeing that the entire colon, that is mainly the rectum, is dilated. The patient had also been given rectal contrast. There is good amount of wall thickening, which is showing enhancement. So this is stercoral colitis, really due to the impacted fecus, which is causing inflammation of the bowel wall. The complication is bowel perforation causing fecal peritonitis. Patient coming with Roux-en-Y and is also an operated case of appendectomy and cholecystectomy. He has a non-settling abdominal pain. What do you think there is? So we are seeing a structure which is showing peripheral wall enhancement, and within it there is fluid density and also multiple air foci which are concentrated at the center. This is a plain scan. These are all contrast scans. So there's not much of wall, except wall enhancement. There is no internal content enhancement, but the air is arranged in a typical pattern, that is a sieve-like pattern. So in a scenario of an operation and the location, that is this patient is operated also for a cholecystectomy. So this is nothing but a gossipy boma. Ultrasound shows the air foci within that collection. So gossipy boma is nothing but seen as a spongiform mass with gas bubbles. In chronic gossipy boma, we can see calcifications within the spongiform fibers, and there can also be presence of a thick enhancing capsule. The contamination of this gossipy boma can result in bowel wall fistulas. Now, this is a patient, is a young patient coming with vomiting. Predominant finding, stomach is humongously enlarged. Within the stomach, in spite of oral contrast, we are seeing content which has lot of air and calcification within. Similar content is also seen in one of the ileal loop. The bowel wall thickening is not much there. Now, this is nothing but a case of trichobazar. This was what was found in patient's stomach. Patient having constipation, obstipation, and vomiting episodes. Easy case, the colonic loop with the apex toward the right hypochondriac, the two limbs pointing towards the left hypochondriac, suggestive of a sigmoid volvulus with twisting of the mesentery. Now, in this case, the mesenteric vessels are well opacified, so we need not think of any associated bowel gangrene. So, this is a simple case of volvulus. And I think this is my last case. So typical signs what we get is bird beak sign if rectal contrast is given, whirl sign because of the twisting of the mesentery and mesenteric vessel. The cecal volvulus will be in midline. It will be, the apex would be pointing towards the, more towards the left hypochondriac region. The last case, patient is coming with nausea, vomiting, weight loss, abdominal pain. There is circumferential wall thickening. There is again an hypodense enhancing wall thickening seen within this bowel wall. And if we trace it, we are seeing fat density content within the lumen associated with any polypoidal enhancing content. On coronal and sagittal reconstruction, we can see this is the interseptum, susceppiens and the interseptum. The interseptum is nothing but the ileum going in the colon and further invaginating into the transverse colon. This is ileocolocolic intersusception with the lead point being a fat density thing and also a polypoidal thing. But when the patient was operated, it was typically a large lipoma causing the intussusception. In adults, intussusception is associated with the intraluminal bowel wall lesion. And I think that is all for today. Thank you for patient listening. And thank you to the organizers and my HOD madam, for giving me this opportunity to present in this.